Okay, let's discuss suicide now. Suicide is a very big problem, and you will come into contact with patients who have either been affected by it, with a family member have committed suicide, or a person who has actually tried suicide themselves in the past. Suicide, as I said, is a very significant problem in the U.S. You know, it's the 11th leading cause of death in 2001. Okay. I'm not going to test you on these statistics, but I just want you to see them to kind of get a picture of how prevalent suicide actually is. Again, the suicide facts I'm not going to test you on, but I thought it was pretty interesting that suicides outnumber homicides by 3 to 2. Suicide by firearms, the most common method for both men and women. Occupations with the highest risks of suicide, physicians and dentists, and nursing and social work have also have an elevated risk of suicide. Suicide also can be a problem in the elderly. The elderly do attempt suicide less often, but they have a higher completion rate, meaning they attempt suicide and are successful, typically because the methods they choose are more lethal. 2/3 of adults over 60 years were in relatively good health when they died by suicide. And 66 to 90% of elderly suicide victims had at least one psychiatric diagnosis. And 2/3 of those diagnoses were late onset single episodes of depression. So depression is a very significant factor in suicide. Suicide in the youth. Again, firearms are the most commonly used suicide method. The largest increase, and please excuse my typo on the screen, that should read largest increase in suicide rates since 1980 has been among black males who are ages 10 to 19 years old. One survey also showed that 1 in 5 high school students has seriously considered attempting suicide in the preceding 12 months. And to me, those numbers are just astounding. Attempted suicide. It is estimated that there are 8 to 25 attempted suicides for each suicide death. Most adolescent suicide attempts are precipitated by interpersonal conflicts, meaning conflicts with parents, girlfriends, friends, someone in and around their personal area, personal group of people. 75% of depressed older Americans are not receiving treatment for their depression, and due to that, they are at increased risk for suicide. Generally, suicide occurs more frequently among people with major depression, bipolar disorder, schizophrenia, alcohol and substance use disorders, borderline and antisocial personality disorders, and panic disorders. And when you look at this, it makes sense. If depression is a major risk of someone committing suicide, well, those with major depression and those with bipolar disorder are going to have depressive episodes frequently. And again, with schizophrenics, they may become depressed as well because things aren't going the way they feel they should. Suicide's not necessarily synonymous with a mental disorder. Someone can commit suicide and have no mental disorder whatsoever, but they are linked. The act of purposefully taking your own life is usually accompanied by very intense feelings of pain and hopelessness, coupled with a belief that no solutions exist. And unfortunately, think of our teenagers. They are all about today, and today their world is over because they broke up with their boyfriend. And that's why, teenagers, those that are about to be teenagers, are at significant risk for committing suicide because they just can't see that this can get better. There are psychosocial factors involved. There are some experiences in which people are more likely to try to act out their suicidal fantasies. Generally, this is loss of love, be it a girlfriend, a mother, a father, your significant other. Narcissistic injury, maybe they were humiliated, they lost their job, or there's a threat of incarceration or going to jail. Another experience in which people are more likely to commit suicide are when they have overwhelming moods such as rage or guilt. And then there also can be identification with a suicide victim or copycat suicides. And sometimes you do see this in our teenage and young adult population. There are cultural factors as well regarding suicide. Generally, there are some protective factors among African Americans. They have generally are very involved in their religion. They have generally extended family members, and they end up being close extended family members, so they have support. Hispanic Americans, a number of Hispanic Americans are Roman Catholic, and that suicide is not something you do in that religion. It's not looked upon as okay to do. And with Hispanic Americans, they also have the importance of their extended family. It may be, it's not just mom and dad and child. Generally, it's grandparents, grandmothers, aunts, uncles, so they have a lot of support systems. With Asian Americans, they do try to adhere to their cultural beliefs that tend to emphasize independence between and the individual and society. And often with Asian Americans, suicides increase with age, basically so that person won't be a burden to their family. And then with the Japanese, they believe in Shinto and believe in reincarnation. And so, that might lead them to feel that it's okay to commit suicide. Some of the things that you need to assess. You need to always assess what your patients are saying. That's when we have to stop, get everything else out of your head, what went on with you this morning, listen to what your patients are saying. Some overt statements that you may hear are, I can't take it anymore. Life isn't worth living anymore. I wish I were dead. Everyone would be better off if I died. Please, when you hear these statements, you need to use your therapeutic communication, and you need to investigate these statements because there may be a real issue going on. Some covert statements that you may hear. It's okay now. Soon everything will be fine. Basically, they've resigned themselves to, I'm going to kill myself and everything's going to be great. Things will never work out. I won't be a problem much longer. Nothing feels good to me anymore and probably never will. Or, how can I give my body to medical science? Again, these are statements that should catch your attention, and you have to delve deeper with your patients to make sure that we find out exactly what they're meaning. When we're doing our assessments, it's very important that we determine the lethality of suicide plan. Basically, what method are they wanting to use? And, some methods are of much higher risk than others. High-risk methods, using a gun, jumping off a high place, hanging oneself, poisoning with carbon monoxide, or staging a car crash. These are generally very lethal methods, and you don't get that chance to go to the hospital and be saved like sometimes people with overdoses do. An assessment tool that we use at times is called the SAD Person Scale. And basically it uses 10 major risk factors to assess suicide potential. Basically, your points are 0 to 10. And as you see, the male sex receives a point for just being a male. Age, you would receive 2 points. You would receive 1 point for each of these. I know I have them numbered 1 through 10, but if your age is 22 to 44 or greater than 65 years, if you're in a depressed mood, if you've had a previous attempt, if you use alcohol, if you have or have had a history of being psychotic and a loss of rational thinking, if you have a lack of social supports, if you have a plan with a lethal method in mind, you get another point for that. And here it's hard to see, but that number 9 actually says divorced, widowed, separated, or single male, because those are big life changes, and those can cause someone to maybe think about suicide where they might not have before those situations. And then severe or chronic sickness, and you add those up. If they have 0 to 2 points, they're probably okay to go home. 3 to 4, you're going to want very close follow-up. 5 to 6, you want to strongly consider hospitalizing that patient. And 7 to 10, you would hospitalize or commit that patient because they are a risk to themselves. So self-assessment. This is when we're talking assessment of ourselves as a nurse. Okay, the extreme feelings that suicidal people are dealing with can evoke very strong negative reactions in the nurse. You know, either you may sympathize with the person, or it may just be adamantly, I just can't believe they're thinking that. So you need to be aware of that and remember that you're not there to express your feelings, you're there to discuss the patient's feelings. It's important to avoid countertransference that can limit effective intervention. The intense emotional reactions of staff need to be acknowledged so that those feelings aren't turned around. Some expected reactions of the nurse that you may be feeling. You may feel anxious, concern for personal consequences, irritation. Feel like the person is just doing it to try to get attention, or that it's a frequent flyer in the ER. And we don't have to talk about that again. Remember, labeling somebody as a frequent flyer often comes back to haunt you at a later date, so try not to get into that habit. Avoidance. Basically, the nurse may distance themselves if the client does not improve so that they won't be hurt if they do go through with the suicide. And denial, minimizing the suicidal ideation, and we need to make sure that we do not get into that to where we are minimizing what they're telling us. We need to take things seriously and work with our communication and our healthcare team to help these patients. Additional parts of the assessment, we need to assess the person for risk factors. We need to look at their history. Do they themselves have a history of having attempted suicide before, or someone in their family attempted suicide? Are they feeling hopeless, helpless? And find out if they have the plan and how lethal that plan is. We need to know what specifically their intent is. Again, the lethality and what type of injury they are looking to do to themselves. Of course, you need to know their age, their medical condition, and any psychiatric diagnoses would be helpful. You need to notice and watch for a change from sad, depressed to happy and peaceful, because sometimes that's not a good sign. Sometimes that is a sign that the patient has resigned themselves to killing themselves. They're peaceful about their thought now. We need to assess what social supports this patient have, if there's any family help out there. We need to make sure that the significant others know signs and symptoms of suicidal ideation to look for, like withdrawal, preoccupation, silence, or remorse. Again, it's just a lot of assessments to make sure that we help this person, hopefully, not commit suicide. So these are some nursing diagnoses you may see: risk for suicide, ineffective coping, hopelessness, powerlessness, or social isolation. So what do we want to happen? In the short term, what we want is that person to refrain from attempting to commit suicide. We would like for that person to express a will to live, express feelings of self-worth, a willingness to call on others for help, call on those support systems for help. We would like to see that person interact with others and to share their thoughts, feelings, and beliefs. Those are the things we want in the short term. Intermediately, what we want to see is that person maintains their self-control without supervision. That person will report a decrease in stress. They're learning to cope with what's going on. We want that person to set goals for the future, to verbalize self-acceptance of themselves and their situation. We want them to accept emotional assistance that others can provide for them. And we want them to feel a connectedness with the people around them, their family, their friends. So we have different levels of intervention for suicide prevention. Primary intervention, these are activities that are going to provide support, information, and education ahead of the time to prevent suicide. Secondary interventions are actually, that's when you treat the actual suicidal crisis. And tertiary, that's when you perform interventions with the family and friends of a person who has committed suicide to reduce the traumatic after effects of that suicide or suicidal attempt. Our basic level interventions that we're going to do, remember milieu therapy with suicidal precautions. We have to provide a safe environment for our patient. That is our responsibility as their advocate. We want to provide counseling for them so that they can talk about the problems they feel that just can't be solved. Health teaching, case management, and psychobiological interventions. Sometimes they may need an antidepressant. Then, if a person has committed suicide, we move to the survivors of completed suicides. What interventions do we need to go through afterwards? With the surviving friends and family, your survivor becomes your client then, not the deceased, when you're looking for interventions to the survivors. You need to clarify to them that they need some type of treatment to talk about or discuss what went on, because that can have devastating effects on friends and family. You need to use the term died by suicide, because you don't want to hide it behind, oh, they died. They died by suicide. It's very important to accept that, and that is very hard for friends and family to accept. You need to show empathy for their situation. You need to examine your own feelings of how you feel if the person that you had gotten to know committed suicide and they're not here anymore. And then you also need to do interventions with the staff, because it is emotional for staff members to lose patients in this manner. Okay, so evaluation. You want to evaluate the behavior changes. Now we're back to the patient now. You want to evaluate behavior changes in the patient. See if there are indications that they are communicating with other people. They're communicating thoughts and feelings and what's going on with them. Hopefully you see an increase of social activities. They want to go out. They want to be in the public. Hopefully they have short-term goals that, in a month from now or 2 months from now, this is where I want to be. This is what I want to do. And that they are progressing towards long-term goals. It is extremely important that we take all suicidal ideation and gestures seriously. I cannot specify that enough. Yes, there are a lot of people that, quote, cry wolf, oh, I'm going to kill myself. But if you don't take it seriously, that may be the one time that somebody goes through with it. So please take that very, very seriously. In some states, they have legally assisted suicide. In Oregon, the Netherlands, Switzerland. Here's where ethics comes into play. It's going to depend on how you feel about that. If you practice in Oregon, are you okay with that? And those are things that you need to think through ahead of time. How would you feel if it was you in a certain situation? How would you feel if it was your family member? It's real easy to say off the cuff that, oh, I would never do that. But should you develop a non-curable disease, there's no treatment, you're suffering, your thoughts could change. It all depends on the situation that you're in. And then I've also given you some suicide hotlines so that you'll have some references for your patients if you need them. Now, here's one thing I want to leave you with. There are times that when you are treating a suicidal patient, they start feeling better. They become better after they've been on an antidepressant. I want you to think about why that is, okay? And It's not always because the patient's getting better. Sometimes after you place a patient on an antidepressant, they do feel better, but now they're going to be more capable or more able to go through with a suicidal plan. So the risk for suicide when someone's on antidepressants can increase for a term. Thank you.